Welcome to, I guess, our second seminar, noon seminar of the semester. My name is Ashu Honda. I know some of you may not recognize me due to my new COVID appearance, all right? Our speaker today is Dr. Rebecca Kreitzer, an associate professor in the Department of Public Policy. Dr. Kreitzer is a political scientist who studies political representation of women in state legislature, ideological polarization among women partisans, and how women legislate on women's issues. Her work extends to studying inequalities experienced by certain groups as a result of public policy, such as state abortion law and same-sex marriage. And she's also interested in how policies diffuse across the country. So basically, almost everything that is a hot topic in the media is likely something that Dr. Kreitzer studies and knows a lot about, which makes her the perfect colleague to have sitting next door to me in the department. Her talk today is on the politics of contraception deserts and how politics around support for Title X has had an impact on women's access to reproductive health care. This work has attracted a lot of media attention and has been mentioned in outlets like the Washington Post, the Atlantic, and PBS NewsHour. So having given that introduction, Rebecca is going to give us about a 35 to 40-minute presentation, followed by a Q&A. I will put instructions around the Q&A into the chat about halfway through the presentation, and make sure that new entrants can read that. If there are clarifying questions during the presentation, I ask that you maybe message those directly to me or in the chat. And if there are enough of those, then I might interrupt Rebecca and ask her to clarify those. So having said that, I'm going to hand it over now to Dr. Kreitzer. Welcome, and thank you for being here.
Well, thank you so much for this invitation to give a talk to the CPC about some of my research. I'm particularly interested and excited to share this research because it's a project that I've been working on since about 2016, which is when I first came to Carolina. And it's taken a while to get it off the ground and taken a while to get it recognized by journals. And in the last year or two, it's really taken off. And so we actually recently got an NSF grant to help us continue this work. So I'm very excited to be able to present it. Actually, this is my first time presenting my work on contraception deserts at UNC. So this is the first time that many of my colleagues have actually seen this research. I also want to point out that one of my grad students, Kellen, Kane, is part of this project. And so he's here in the audience watching. And so I wanted to point out that he's been a critical part of this project as well, especially with doing the computation of measuring contraception deserts, which is pretty laborious. So he will be here as well throughout the talk. Okay, so the reason why I became interested in this topic is because my dissertation and a lot of my early work is about abortion policy and the complexity of abortion policy and also the politics surrounding it. And what I noticed is that it used to be the case that people were supportive of contraception. Why? Because contraception reduces the abortion rate, it reduces Medicaid costs, and yet very few people study contraception. So it's like far more people need access to contraception, but there's been a lot of scholarly focus on abortion. Only 39% of women who need affordable family planning are able to access it, in part because of administrative burden, in part because of like spatial geography reasons of it actually just being difficult in order to find a place where you can obtain it. And as a result, and we also know that there's just in general a strong relationship between space, health, and race. Part of this has to do with the history of redlining and the provision of public health resources, like where they're located. And so my team and I wanted to study kind of the interaction of space, health, and race, especially when it comes to contraception. So we're focused in this project on Title X. So you might be thinking, like, why are we focusing on Title X, this one program? Well, it's the only federal program that's dedicated exclusively to family planning. So there are other programs that also provide some money to family planning, but family planning isn't their primary mission. Historically, the program has focused on access to affordable, voluntary, evidence-based contraception, and they've really targeted providing it to people who need it the most. Given that it is federally funded and publicly funded, we might have some expectation that the resources of Title X are equitably distributed. So that's really the question that we're getting at with this research is, are these public funds distributed in a way that makes sense? Okay, so what does Title X do? Well, I put did in parentheses because a lot has changed in the last few years, especially under the Trump administration. So first, let me talk about kind of what Title X is supposed to do. So the way it works is that grantees can apply to the federal government in order to get funds, and sometimes they'll have sub-grantees. And so grantees are required to offer what, quotation here, a broad range of acceptable and effective medically approved contraception methods and related services. These services were required to be provided on a voluntary and confidential basis, including to unemancipated minors. They were required to, or they very often also provided other very important health services like cancer screenings, testing and referral, different prevention programs. And these services had to be provided regardless of income, but they could have a sliding scale. Well, why is that important? There's a lot of people who are in need of contraception that maybe can't put it on their own insurance, perhaps because they don't want their partner to see. That's not an uncommon thing. And these people wouldn't necessarily qualify for getting contraception in other ways, like through Medicaid. And so it's very common, especially after the ACA mandate of part of Obamacare, that made the demand for contraception to be even higher. And so there was an increase after that of people who were using Title X. Okay, a few more things about Title X. It's important to note that Title X clinics are physical locations, as opposed to other programs like Medicaid, which work via reimbursement. So in the past, as of 2018, there were some 4,000 locations that served about 4 million people. But because of Trump era policies, in just 1 year, that reduced down to only 3 million people served, and about, I think it was 934 clinics had to close. So almost 1 in 4 contraceptive or reproductive health clinics closed. It's also important to note that these Title X clinics are different than other clinics in that they focus on reproductive health. And so they do tend to offer this quote, full range of contraceptive methods, as opposed to other clinics like federally qualified health centers. So FQHCs are clinics that qualify for reimbursement for Medicaid and Medicare, as well as other requirements, like they have to provide a range of comprehensive services, but reproductive health care isn't considered comprehensive services in those provisions. It's also worth noting that Planned Parenthood has come to serve about 41% of all Title X patients. So they're a really critical part of the program, and that Title X really serves people of color in particular. So about half of all Title X clients are people of color. So here's the pop quiz portion. Which famous president said this? So it is clear that the domestic family planning services supported by the federal government should be expanded and better integrated. It's my view that no American woman should be denied access to family planning assistance because of her economic condition. So as you all know, that was from the great liberal Richard Nixon, and that Title X actually ended up passing with very broad bipartisan support in 1970. As an aside, Nixon in general was pretty progressive on women's issues, including starting a national task force that dealt with it. But this is pretty representative of the state of contraception in 1970. People were generally supportive of it on a bipartisan basis, in no small part because providing contraception reduces abortion. Okay, so I want to start by showing this map of Title X locations. This map is from, I think, 2016. And the reason why I'm showing an old map is because they changed the color scheme and it's harder to see on presentations, but it's mostly the same from 2016 to 2018. I could look at this map for like an hour. There's so many things to see and unpack with it. The first thing that you might notice is that in the Southeast, there are a lot of clinics, and that you might have been thinking, like North Carolina, we tend to be a little bit conservative. Why would these Southeastern states have so many clinics? Well, part of it has to do with the history of public health and the way that county public health departments provided services, especially in the Southeast in the past. So there's some path dependency there. You'll see that it's in the Southeast, it tends to be that every single county has its own Title X clinic, usually provided through the county health department. You'll notice other states like California and Texas, which are the two most populated states in the country, they look very different. Instead of having clinics all over the state, they tend to be focused in areas where the population is. So this gets us kind of thinking about, like, what does equity of access mean? Does it mean that you don't have to go that far in order to get Title X, which might mean that the Southeast is doing the best job? Or it might mean that you put the clinics where the most people are, so that the most people have the best access. And that might be closer to like what California and Texas are doing. So we became kind of interested in, like, what are the different ways that Title X is implemented across the US states, and kind of like which approaches to this do the best job in serving the people. It's also worth noting that there's differences in just how many clinics exist. So California and Texas, again, are the two most populated states. And California has, I think, 3 or 4 times the number of clinics that Texas has. So in this project, we wanted to get at a measure of how much access people have to affordable family planning. So we coined the phrase contraception deserts. And to start off, we wanted to start with a conceptual definition. So conceptually, what does it mean to live in a contraception desert? Well, we didn't want it to be just access in like the distance it takes for people. We don't want, the key thing about equity of access is we wanted to make sure, or we wanted to differentiate between places like the Southeast, like North Carolina, where there's tons of clinics, and so it doesn't take a long time to get there, but they aren't more clinics where more people are. And so we landed on this definition of access, equity of access, which is that it exists when services are distributed on the basis of people's need for them. Because after all, we should be caring more about where the people are than just like where space is. Okay, so in order to do this, we first started looking at how other people have measured health shortage areas in the past. So the traditional way of measuring a health shortage area is to use a patient to provider ratio, often called a PPR. And this typically is done within an administrative boundary. So if you look at like the federal government's definitions of health shortage areas for various different health disciplines, you'll often see that they're calculating these at an administrative boundary like a county or a zip code, which is actually a pretty big administrative boundary. The benefit of these measures is that it's pretty intuitive for most people to understand. A simple ratio within a boundary, most people can kind of wrap their heads around it. But it's problematic in the sense that it ignores the spatial distribution of where providers and patients are located within those administrative boundaries. And it also ignores just the realities of like how people travel. It's worth mentioning that if you're looking for like a new dentist or something, very few people are thinking, oh, I want a dentist that's in my zip code. Instead, people are thinking, I want a dentist that's in a reasonable driving distance of where I live. And it might be in a different zip code, or it might be in a different county. And people just really don't think about administrative boundaries. They think more pragmatically about how long it takes to get places. So a method that became increasingly common, especially in the field of applied geography, is using what's called the floating catchment area method. So we're actually using a kind of ramped up version of that method, but I'll start with what the basic method is so you can wrap your head around it, because it's not as easy to understand as the patient to provider ratio. So the basic floating catchment area approach draws an X-minute polygon, which is called a catchment, around the center of a census tract. And then it calculates the patient to provider ratio there. So already we're improving a little bit over the previous methods because we're using census tracts, which are much smaller, as opposed to using things like zip codes or counties. After that, there's an advancement that says, but wait, sometimes where the people live in a census tract is not the center of it. Maybe everybody lives kind of over by the edge of a census tract. And so the two-step floating catchment area kind of repeats what happens in the first stage, but it does it first by looking at the catchment areas around provider locations, and then again around the population centroids, and tries to calculate like how much access there is based on where people actually live. The integrated two-step floating catchment area method, which is what we're using, adds another layer to that. So after we do this process of the two-step floating catchment area, we then also merge that in with data about the percent of the population that's below 150% of the federal poverty line. The reason why we want to do that is because we want to differentiate between contraception deserts where there is not necessarily a high need. Maybe it's in a wealthy area, or maybe it's in a area where people just like have low need, compared with areas that are like there's no access and there's a lot of people, or there's a lot of people of color who have traditionally had a more difficult time using or obtaining health through like Medicaid and Medicare, in part because those programs have a significant administrative burden. Okay, so in order to do this, we first collect data from the American Communities Survey in order to get demographic data about like the race and ethnicity of people, as well as the poverty levels. And then we also use clinic locations from the Office of Population Affairs directory from July 2018. And that's the current work that I'm going to show you today. Our plan is actually to continue this work and draw comparisons between what was going on in 2018, what's going on later. After we do this, we are confronted with this question of what's a reasonable driving distance? What is a reasonable driving distance? Well, it might vary substantially based off of the type of specialist that you're seeing. So often in the literature, especially for primary care physicians, they use a 30-minute driving distance. But a reasonable driving distance might be longer or shorter for different types of services. Like few people actually would go to a pharmacist that's 30 minutes away. And so things like contraception, many states actually have laws that limit how many months of oral contraception you can get at a time, for example. So many people would have to see a reproductive health clinic maybe 4 or 6 or more times in 1 year. The other thing that's important to think about is what's a reasonable driving distance if you live in the country versus what's a reasonable driving distance if you live in Durham. And so we think about reasonable driving distance as varying based off of the type of place that you live in the country. So we use the rural urban commuting area scores, which are also provided for by the census. And this is based off of how rural or urban an area is, but also the traffic patterns, like how easy is it to get into like an urban center. We do it based off of like little categories. So like RUCA scores of 1 to 3 are 15 minutes, and that's like the most metropolitan area. And then we scale it down for the other areas. We assume that people in rural or isolated areas, a reasonable driving distance to clinic might be 45 minutes or 60 minutes. Okay, so you might have gotten a little lost on the last few slides because it was kind of complicated. So for the visual people in the room, here's the same thing that I just said, but with some pictures. So we started our process by geocoding the locations of population centroids, as well as clinic locations within census tracts. In step 1, which is the first box, we draw a polygon around each clinic, varying what a reasonable driving distance is based off of those rural urban commuting scores. We then calculate the total population of reproductive age, which is considered by most of the literature to be 15 to 44. And then we sum up what the population is, and we use that as the denominator in the next step. Okay, so in step 2, which is that second box, we then draw a catchment, a polygon around each of the population centroids, again, based off of these rural-urban commuting classifications. And then we calculate a clinic to population ratio using the denominator from step 1. And then we identify in that third box, any census tract where the population centroid doesn't reach a clinic is then given a spatial accessibility score of 0. Okay, so all of this comes together. We define and calculate some things, and we come up with a spatial accessibility score. And in really simple terms, it's basically a ratio of the sum of clinic counts over the sum of clinics available to the people in an area. And I hope that that was clear. I know it's kind of complicated to explain. So we define mathematically a place is considered a contraception desert if it has 0 spatial access. That's like in that third box that I showed you on the previous slide. So these are areas where the population centroid is not within a reasonable driving distance of a clinic. And in those areas, we color them kind of a medium blue color. In areas where there's no spatial access and there's greater than 1 standard deviation above the mean of the percent poverty below 150% of the federal poverty line, we call those areas high needs populations. And so in the following maps, these places are put into a dark colored blue. So we haven't finished doing all of the states, but actually it's worth pointing out that this is already very computationally taxing. Most studies that use this method look like at 1 state or 1 urban area, and very few are looking at a national scale. In fact, we've only run across a couple of papers. That's our end goal, because what we know about Title X and other reproductive health services is that people often have to cross state lines in order to obtain it. So right now we are calculating our contraception deserts state by state, but eventually we want to do it to take into account the fact that, for example, people in Tennessee might cross over to the border in order to go to a Title X clinic in Asheville, for example. You can see that places like Texas and California, which I drew attention to earlier, both are very populated places, both put their clinics in population centers. And so you can see that in the big cities, there aren't contraception deserts, but a lot of the areas outside of that are. What you'll see is also that there are way more contraception deserts in Texas than California. Part of this, of course, is geography. They have more space to fill. But part of it is the fact that California has, I can't remember if it's 3 or 4 times as many clinics off the top of my head, but they have far more clinics, which is why they have fewer contraception deserts. Here's North Carolina, just because we all live here so you can see it. If you remember that one map that I showed of the whole country and all the clinics, North Carolina has a clinic in just about every single county. And so you can see that in most of these counties, there is a little area where there's no contraception desert, and that kind of is centered around where those clinics are. But for the most part, North Carolina is looking pretty good, right? Most of the urban areas are very safely not in contraception deserts. And even if you're in a contraception desert, you don't have to go that far in order to find a clinic. We tabulated then what is the percent of the population of reproductive age that lives in a contraception desert, as well as the raw number of people, so that we could ascertain how many people are directly impacted by this. What you can see is that the percent of the population that lives in a contraception desert varies from a low of about 17% of the population in California to above 50% of the population in Indiana. Indiana, historically, maybe you recall that Vice President Pence used to be the governor of Indiana. And while he was the governor of Indiana, there were a number of efforts to restrict access to contraception and abortion, including the very famous Periods for Pence campaign. So you can see that this amounts to a lot of people, especially in certain states. Okay, here's a slide that has just so many words. And part where I put this up is to show that so much has happened in recent years. So whereas we've seen some changes kind of historically, very few changes from 1970s up until more recently, really in the last 2 decades, it's been like a flourish of activity, and especially once Trump became the president. So some of the things that we saw in Title X were changes like they took out the evidence-based contraception. So you no longer had to provide a wide range, and you no longer had to provide contraception that was evidence-based. So what that meant is that some clinics, particularly in California, lost funding, and instead crisis pregnancy centers, which do not provide science-based contraception, ended up getting funding by this program. There were a number of other things that the Trump administration ratified into like rules for Title X, including things like there has to be a physical location difference. So a Title X clinic couldn't have any overlap in the personnel or the space with places that provided even information about abortion. So that immediately caused a big problem, because tons of places like Planned Parenthood are places where you could get an abortion or you could get family planning. And so a lot of reproductive health clinics will have days where like 3 days a week they do abortions, or 2 days a week they do abortions, and the rest of the day they do just other family planning needs. So this rule was hugely detrimental. There were a number of other rules as well. And what happened towards the end was that about a quarter of Title X sites said that they could no longer accept federal funds. They couldn't participate anymore. And that included 400 Planned Parenthoods and 600 other places across a number of states. It goes without saying, this dramatically changes the nature of Title X. It goes from being this program to provide science-based contraception to low-income people, to being a program that was providing money to like crisis pregnancy centers and not so much focusing on the need to provide it to low-income people. Well, in order to show the potential impact of this, and even we started this work even before clinics started saying they weren't going to accept funding, we wanted to look at just like hypothetically, what would happen if we eliminated Planned Parenthood? In part because there have been a number of bills, both in Congress and state legislatures, that have targeted Planned Parenthoods in particular and saying that they wouldn't be allowed to get funding. In fact, we even had bills like that here in North Carolina. So in this following analysis, what we do is we first map access to Title X with Planned Parenthood, which is what I already showed you. But then we also show what it looks like if you were to just take out those Planned Parenthood clinics. So our intention here is to show that simply just like defunding Planned Parenthood would have a really significant impact in people's access. So in particular, we ask questions about like, what does access to Title X look like when you get rid of Planned Parenthood? Who lives in contraception deserts, and how does that change? So in order to do that, we repeated the steps that we did the first time, but we ran it twice. Once with Title X clinics that aren't Planned Parenthood, and one with Title X clinics, with Planned Parenthood, and then we compared the difference. So places where a census tract initially was not a contraception desert, but without Planned Parenthood becomes one, we call expanded contraception deserts. And these are colored in yellow in the following pictures. So you can see a place like California, which already had some of the best access. Before, they had only 17% of the population was in a contraception desert. Well, when you take out Planned Parenthood, many of which are located in urban centers, it significantly increases the number of people who would fall into areas with low access to family planning. Here's a whole bunch more states. What you can see is the degree to which the Title X program relied on Planned Parenthood varies substantially across the US. Here in North Carolina, we have 99 clinics that are county-based, and we have 4 Planned Parenthoods. So getting rid of Planned Parenthood doesn't have a huge impact on Title X here in North Carolina. But in states like Washington and New York and California, it does. It has a big impact, especially on the population centers. One thing that's important to note is that when we expand these contraception deserts, it's oftentimes the people that we think of as being like the intended targets of the policy that are now being excluded. So what this table is showing is just the raw number of people by these different groups in each state that is now in a newly expanded contraception desert. So for example, in California, which I talked about before, with expanded contraception deserts, an additional 1.5 million people would no longer have access. you can see that it amounts to a lot of people. So just in this 10-state sample, it amounts to 4 million people that are no longer in a place that has easy access to affordable family planning. Okay, so the quick implications of Trump's revisions to Title X were very substantial. So very quickly, about 20 Title X grantees. So grantees are sometimes like the state of North Carolina, as well as many subrecipients pulled out of the program, in part because they explicitly had to sometimes, and sometimes it was like they couldn't make it work with these new rules. We saw that there was about 1 million fewer clients were served in 2019 than in 2018. That is a huge decrease in just 1 year, especially given the overall size of the program. We also saw that it in particular decreased access to areas where low income, uninsured, and racial minorities live. We also saw that in addition, like we can calculate, we know the exact details about Title X because of how many people receive different types of contraception, because of the way it operates. It also operates on a reimbursement system. So we know that there were like 225,000 people fewer received oral contraceptives in 2019 compared to 2018. There were also far fewer Pap tests, clinical breast exams, et cetera. So the health implications are pretty significant, including going beyond just the access to contraception itself. Well, overall, our findings are that Title X access is not equitable across space and not even equitable within a single state. Contraception deserts range from California, which is about 2.8 million people, to 50% of the population in Texas, which is about 5.8 million people. States where Title X is implemented through the counties, like North Carolina, kind of equally distributed across the state in terms of like geographic space, tend to have fewer contraception deserts, but not necessarily a lower percent of the population that lives in those contraception deserts. So instead, it's places like California and Texas, which are focusing the location of their clinics in population centers that have the fewest number of people who are in them. It's also a very clear pattern across all of our analyses that low-income people and people of color are disproportionately in contraception deserts. So for example, 38.8% of Californians are Latinx, but 68% of those in contraception deserts are Latinx. In Colorado, less than 1% of the population is Native, but 11% of the people who live in contraception deserts in Colorado are Native. One thing that is important to note about this is that defunding Planned Parenthood significantly increases these inequalities, and FQHCs and Medicaid don't fully fill in the gap of losing Planned Parenthood, in part because FQHCs and Medicaid are not physical places that focus on reproductive health care. So they tend to provide a smaller range of options, and sometimes they don't offer very much at all. There's also a higher administrative burden. And so we know that lower income people in particular struggle with that administrative burden in order to receive services. In May of 2021, the Biden administration did put forth a new rule that would undo a lot of what the Trump administration did. But it's worth noting that there doesn't seem to be a great sense of urgency because the notice and commenting period for that ended in June, and we haven't heard anything since then. And it's likely to take months or years before the new rule goes into effect, which means that in the intervening months or years, there's going to continue to be this significant decrease in access to affordable family planning. Okay, so I'll end with talking a little bit about what we plan to do with this. So mapping contraception deserts has been a very laborious process in terms of collecting the data and kind of conceptually coming up with it. But we're on track to finish mapping, we think, about all states this year as of 2018. After we finish that, we're also going to redo the whole process, but looking at the clinic locations in 2020. So we can assess the degree to which these policy changes in 2019 had an effect on access in 2020. In particular, we're interested in questions about who lives in these deserts, who is living in these areas where they lose further access as a result of these new rules in Title X. We also plan to look at the political context of the state legislature and the governors to see how those policies are made, and kind of, is there a relationship between, like, for example, the presence of women in legislatures and better access to affordable family planning. As part of this, we plan to do interviews with people at OPA, as well as state and regional directors of Title X, in part because what we've learned in our preliminary interviews is that the implementation varies pretty widely across the US, and in interesting ways. And we also learned some kind of interesting tidbits. So for example, I talked to a nurse who's a Title X clinic in Washington, which is one of the states that really relies on Planned Parenthood. And what she found was, or like what the concern was, that as they started to defund these programs, as there started to be increased immigration enforcement, what they found was that that immigration enforcement would kind of hang out in the Title X parking lot of their clinic, because those people, undocumented people, didn't have access to affordable family planning at other places other than Title X clinics. They can't qualify for Medicaid and Medicare reimbursement. And so the people who are taking advantage of these programs are really vulnerable. So we're really interested in kind of like who is the clients of Title X. Our eventual project is to work on a big book project. My colleague Candice Smith, who used to be here at UNC and now is down the road in Durham, she is an expert in writing books, especially ones that target kind of a public audience. Because Title X is this program that we really want to educate the mass public about, we are targeting our book towards being one that works for a mix of scholarly audiences as well as the mass public. The last time a big article came out about Title X and the politics of Title X was in 2001, and a lot has changed since 2001 when it comes to Title X. So our goal is to kind of update that. And in particular, we're interested in these themes of like federalism and how federalism perpetuates inequality, as well as the relationship between these public and private partnerships, among other things. So I'll leave it there, and I'm really excited to hear what questions and comments you all have.
Thank you so much, Rebecca. Really exciting work. So exciting, it's happening right next to me in Abernethy Hall. Great, so our next step here is to go into the Q&A. So as I mentioned in the chat, I'll look for hands being raised. There are a lot of people and I only have one screen, so I'll have to filter through the screens. And in addition, you could also write your questions in the chat to me, and I'll read them on your behalf. If you could turn on your video, that would enhance the experience for everyone as well. I'll leave that up to you. So right now I'm seeing Alice, and just checking. I thought I would try and take a couple of questions at a time, Rebecca, just to see how well you can focus. But I only have one question right now. So Alice, go ahead with your question. Then I've got a question in the chat. I've got some more. Go ahead, Alice.
Thanks, Rebecca. Thanks so much for this great presentation and sharing the results and the plans for what you're going to do next. And I actually was wondering if you could comment on how you think trends in the need for services from Title X may have changed in states that expanded Medicaid versus did not. And if you're thinking about including, I mean, that's sort of going back, and I'm interested in this because I'm going to be looking at this for my dissertation research, but like that would involve, I guess, like going back, which you may not have the capacity to do, but just curious if you've thought about like incorporating that into the analyses as well.
Yeah, great question. And for people who aren't aware, Alice has done great work on abortion deserts, which is a related topic. Yes, we are interested in Medicaid. It's an important dynamic. So one thing that we've already looked at a little bit is within our analysis of looking at the effect of Planned Parenthood, of the 10 states, most of them were states that did expand Medicaid, not all of them though. And so it is interesting to us to see, that's part of like our interest in the politics of it. So if Medicaid is expanded, does that help decrease the demand for these policy or for Title X? And so we hope some of that is revealed in our interviews with the people who actually work at these clinics. it is our plan to continue to track that. I was going to say something else, but now I can't remember what I was going to say. Oh, yes, and I remember now. So the other thing that is worth noting about Medicaid expansion is it's great. So definitely I'm advocating for we should do that. But in order to participate in Medicaid, there is an administrative process that is taxing. You have to fill out a lot of forms. Then you have to find a clinic location that is willing to see you. And not all FQHCs are taking on new patients. Not all of them provide reproductive health care. A lot of them focus more on, basic heart disease and diabetes and things like that. And they're just not concerned with reproductive health care. So that's another thing that we are interested in seeing is which clinics are participating and what types of contraception are they providing. And so our concern is that yes, Medicaid expansion is good, but it's not necessarily filling that gap if it means that people are needing to one, overcome this administrative burden, and then two, go to places that don't necessarily have the resources that they need.
Thank you, Rebecca. We've got a question from the chat, which I'm going to read. How was access through public transit included in the analysis? I guess the person believes that you defined access in terms of car distance travel, right? Maybe you can clarify.
Yes, that was an important caveat that I forgot to mention. So you can do this analysis by looking at public transportation, but then you're limited in only looking at places that have public transportation, which tends to be small areas within a state. So for example, the cities of North Carolina. So our driving distances are based off of if you have a car. We do include non-paved roads in rural areas as being part of the transit system. But it is worth noting that a 15-minute driving distance in an urban area could easily still be a 45-minute trip for somebody who has to catch a bus or two in order to get there.
I'm not seeing any other hands raised. Is that true? Barbara, over to you.
Unmute, Barbara.
You're still muted, Barbara.
Sorry.
There you go.
Yes,
All right.
Thank you. We'll all get good at this muting thing, hopefully at some point. Anyway, thank you for the talk. It was interesting. My question is an obvious one, but I would love to hear your thoughts about it. I mean, you were emphasizing all of the policy changes that took place over the past 5-6 years, but of course, we've also had a pandemic. And, I wonder how that influences what you think you're going to find. In particular, when you do your interviews, you're going to be hearing people's reflections about a time that's really quite different than the one that's reflected in your 2018 data and possibly even the 2020, since it's based on not only distance, but the fact that people felt comfortable going those distances. And so I wonder if you could just reflect on that. I'd be curious to know your thoughts. Thank you.
Yeah, that's a great question. I don't know if I've thought about that in as much detail as I should have. I think we do hope that it'll come across in our interviews, that we'll be able to learn a lot about the process and who was attending clinics as clients before the policy changes. In our preliminary interviews with people who participate in Title X, they seem to have a great rich knowledge of how things were at different points in time. We used to have this many people and these are the people we serve, but then this law passed and then we had to change our services in kind of this way. So our hope is that those qualitative interviews, though looking back, retrospectively, will help us to fill in some of the complexity and nuance that is missed in just looking at these quantitative numbers across the board. I do expect that the pandemic would have shaped the need for Title X in a couple of ways. One is that many people lost access to employer-based health insurance. And so for a lot of people, they suddenly became uninsured. And so the only place for them to get affordable family planning would have been through programs like Title X. And we also know that people have become, we know that many people have neglected their health in the last year and a half because they haven't wanted to go to clinics. So I am interested to know if to what degree that has shaped the number of people who have attended or gone to Title X clinics, though I would think that because the many people are very actively trying to not have children or time their pregnancies, perhaps Title X clinics were places that they would go either way. One thing that we are lucky to have is the benchmarks of 2018, and we already know that there was a significant decrease in clinics and clients in 2019, which is before the pandemic, as directly as related to policy.
Thank you, Bob.
Great, thank you, Ashu, and Rebecca, thank you for a great talk, super interesting, and it's good to see you again. Although every time I see you, it's through video.
That's true.
Anyway, so my question is more clarification than anything, but I guess I want to go back to the granting process. And I was really struck by how, when you looked at that map, the contrast between something like North Carolina versus Texas or even California, and you talk some about the Southeast in general versus other places. So are the grantees, you said some of them are states, but maybe not all of them. Can you give us a little bit, maybe I'm the only one, but give us a picture of who are the grantees, and more generally, are individual clinics, can they be grantees? Because I'm trying to understand this reduction from, I think you said 4,000 to roughly 3,000. And are we losing individual clinics? Are we losing grantees? Both? So it's a convoluted question, but it's more, I'm trying to understand the actors here and how they're associated with establishing these clinics, and then how they may be associated with them going away.
Yeah, that's a really important question. And I did kind of gloss over that process just with the nature of time. And I think it's actually something that most people don't know. So I think you're not alone in kind of wondering how that process works. So the way Title X operates is they put out a call for applications to the program each year. And with that, they'll have like the requirements. So like I said, it used to say that you had to have a broad range of evidence-based contraception, which it no longer says that on the grant application. It hopefully will start saying that again when the Biden administration's rule goes into place. So any organization can apply. So in some states, like the Planned Parenthood of Minnesota, for example, could apply if they wanted to. And another place, it's like the state health department. So here in North Carolina, the state health department is a grantee, and then they provide funds at their own discretion how they do it actually to their sub-grantees. They have a lot of discretion in how they allocate those funds. And there's also a pretty broad range, even within North Carolina, of the types of contraception that's available at different clinics. And one thing that we noticed is that in poorer areas, they tend to have fewer types of contraception available, in part because like more expensive contraception like LARC, long-acting reversible contraceptions like IUD, because it works through reimbursement and stuff. So that was a little bit of an aside. One thing that's interesting to us is kind of the path dependency of policy. So historically, especially in the Southeast, public health in poor areas post-Reconstruction was provided by county health departments, which is one of the reasons why we see in the Southeast this preponderance of most Title X clinics are county health departments or affiliated with them. You're probably looking at Georgia and thinking, my goodness, what's going on with Georgia? Well, interestingly, a couple of years ago, a consortium of FQHCs came together and put in their own grant that competed against the state of Georgia in order to get Title X funds. And they put together a better grant application. And so the state of Georgia no longer is a provider of Title X. Instead, it's through these FQHCs. Some places are individual grantees, and some have 3 sub-grantees, and some, like North Carolina, have like 100 sub-grantees. What we know of the number of clinics that have decreased from 2018 to 2019 is of the 900 or so, about 400 something of them were Planned Parenthoods, which were pretty explicitly excluded. And then the remaining like 650 or so were just private grantees. And so some of those were independent clinics, and some of them were ones where there were a number of clinics associated with it.
Thank you.
Bob, you're happy with that?
Yes, I know way more than I used to.
I don't see any other hands at the moment. Do we not have any other? All right, Young, go ahead.
Can you hear me?
Yes.
We can. Thank you.
Okay, great. Thank you very much. Terrific presentation. I'm very intrigued to try to draw the connection between contraceptive service and fertility, because I study fertility. And by logic, we would see a Trump-Pence effect on fertility. And that would mean that without contraceptive variability, we would see a increase. But we know because of pandemic, because of the economy, U.S. fertility has been on the decline side. Mm-hmm. So can you speculate or fill us in, say, hey, what's the disconnection here?
Well, we're really interested in fertility as well as like maternal health. So part of our NSF grant is actually to start comparing the prevalence of contraception deserts with a range of health outcomes. So some of them having to do with maternal health, some of them having to do with like what's the unintended pregnancy and what's the abortion rates in different places. So you're calling it like the Trump-Pence like fertility bump. I mean, I think that we could potentially see that. That's definitely the concern about closing this many clinics. It'll be a little bit difficult to untangle everything with the pandemic happening at the same time, which we know has also suppressed fertility. But maybe we'll be able to start seeing some differences. I haven't looked at all the data yet, but just like 2018 through the 2020 data, we'll have to see if there's some meaningful trends there.
Any other brave souls with a question? You could always type it in the chat and I can ask on your behalf. Carmen.
You're on mute.
Hey, Rebecca, thanks so much for your time. Your work is really awesome, and you and Kellen and Candis and others have done such a nice job on this, so thanks again for sharing. I had a couple questions. One is kind of technical and the other is sort of speculative, but I was wondering in terms of the ways that you all calculated contraception deserts. I think you mentioned that the denominator, I really liked your slide telling us about like the steps that you in the mapping process. I appreciated that. And I think I remembered that you mentioned that the denominator was like the entire population of the area.
It's so complicated. In order to fit words on the screen, I had to like cut out some things to make it like really clear. So yes, what is happening is that in the first step, so step one is kind of like that first box, what you're doing is you're calculating the percent of the population in reproductive age that is part of that population centroid. And then in the second one, in the second step, you're doing it, sorry, I said opposite. First, you're doing it around the clinics, and second, you're doing it around the population. Part of the complicated math is that you have to make sure that you're not double counting people. So I kind of glossed over that just a tiny bit there, just for needs of space. So the first one is like, in step one, you're identifying like, what is the percent of the population that's within a driving distance to a clinic? And then in the second one, you're weighting it around not the center of this population, not the center of the centroid, but instead where the population is. And so what you're doing in the first step kind of becomes the denominator in this step. And I kind of sped over some of the mathematics of it just because it's kind of complicated. Kellen, my grad student, is here who made these very beautiful figures, I believe. It was either him or our other grad student who's on it. And if he has corrections to what I said, I'll let him unmute himself and clarify and correct me.
Yeah, we want to hear from you, Kellen. Come on, say something.
Hi, everyone. So just to kind of add some detail there, you can kind of think of the first step of the process as coming up with like a clinic to population ratio. And where there's areas where a specific clinic is serving a greater portion of the population, that gets factored into the second step when we kind of assess how many different census tracts are going to this one specific clinic.
Thank you. It's a lot of like technical, you have to be really careful on how you're describing it. So I appreciate Kellen clarifying there. I don't know if that clarified your question though, Carmen, because we can help you show you the math if you're interested later.
No, it's really interesting. I think you all did a really thoughtful job here. I was curious. My first question was going to be about the denominator, and it looks like you are controlling for like the reproductive age population specifically.
Mm-hmm.
I wasn't clear about that just on my notes. And then I guess I am also wondering about like, how are you accounting for gender as well? And then my other question that's just sort of speculative about, you know, how you all are going to be working on this in the future is, you know, Barbara had mentioned the pandemic, and I understand that that's something you'll be thinking of a lot in understanding access and changes in access. And I was also wondering, I don't know how exactly you could account for it, but the ways that increasing numbers of extreme weather events might be affecting access in terms of clinics and contraception.
Yeah, so to the first question, and in these analyses, we're basing it off of the population that's between the ages of 15 and 44, inclusive of gender. Though we've also run some models where you're just looking at women of reproductive age, and the analyses are like analogous, right? Because for most states, we haven't mapped Alaska yet, which is really the only state where there's such a big gender imbalance. Part of the reason why we've chosen to use a population that is inclusive of gender is in part because Title X clinics do more than just serve women. They also serve men. They do vasectomies as well as provide things like condoms. And men also go there for STI screenings, among other things. So we intentionally included inclusive of gender for that. To the second question, I think there's so many different things that can affect access, and a large part of it is just how to overcome the barriers of geography. So anytime there's anything that makes it harder for people to move across space to obtain services they need is going to have an impact, including weather events, which would impede people's ability to access perhaps public transportation or maybe even just regular transportation. And so weather events, pandemic shutdowns, I'm sure that also probably had an effect to some degree of people being able to kind of move to different parts of the state or country in order to get not just contraception, but abortion too.
Thanks, Rebecca.
Great, thank you. Listen, I think that it is 12:59. We do pretty much go with a hard stop at 1 o'clock. So I think I'm going to go ahead, Rebecca, and end it here. And thank you and Kellen for this great work, really interesting stuff. And we hope to see you in a couple of years when you've finished all the work. All right.
Well, thank you for allowing me to present this. I'm very excited to have shared it, especially with UNC people, since we've been plugging away.
Great. All right. Thanks a lot. And we'll see everyone else next week.